We are the Pharmacists Society of the State of New York, and we are here this weekend bringing hundreds of pharmacists from across New York State together to discuss the issues at hand to help improve patient care and to improve that patient care. The Pharmacists Society of the State of New York represents the interests of more than 25,000 licensed pharmacists across New York State. PSSNY vision is to serve New York pharmacists and the profession of pharmacy with advocacy and resources to improve patient care. Pharmacists are the second most trusted profession, according to a 2017 Gallup poll, and the most frequently seen healthcare professional for most patients, providing unique opportunities to improve patient care and the overall public health of the communities they serve. The pharmacists are trying to improve patient care in the communities they serve, and we are here this weekend to discuss the issues that are barriers to that goal. And we are working through our policy and reaction to the governor's state budget and the bills that we would like to see passed to help assist in the patient care.
Pharmacists are fortunate to be on the front lines of patient care. We're your most accessible healthcare provider. We're the ones who see the patients the most, and we're the ones who stand on the front lines in trying to improve their health outcomes.
I think it's important that you know your pharmacist. Most people associate their pharmacy with a brand name such as CVS or Walgreens, but you really need to know the person behind the counter to have a relationship with them to make sure you're getting the proper care.
We're committed to making sure the patient gets the correct medications. Sometimes just access to their medications can be a hurdle that has to be overcome. We can do that. We can educate them on how to take their medications in the most appropriate way to get the best effect and to keep them healthy and keep them out of the hospital. Licensed professionals like the pharmacist work in a variety of settings. We work in community, we work in hospital, we work in long-term care and many other settings, with the intent that we're going to make sure the patient has the appropriate prescribed medications, working with the other members of the healthcare team to get them well and to keep them well and give them a better quality of life. The pharmacists are the most accessible healthcare professional, and there are many times that we will in any setting get calls or be asked for information about medications. And it's very good. We want the patient to be educated, to know what they're taking, if it will react with other things, if it has side effects, things for them to look for.
Patient right to access to care is very important. Millions of Americans are struggling to find primary health care in their areas. This will only continue to expand as the demand grows. Over the next 2 decades, the Medicare enrollee population will increase by about 60%, moving closer to 80 million people. This is very critical because the federal landscape today is very unknown, and it's very important that the patient's right to care is protected. The pharmacist-patient relationship is critical to the overall healthcare system. And as the most accessible provider in the healthcare system, pharmacists recognize this and focus completely on improving health outcomes for their patients, providing a higher level of quality of care, and therefore reducing overall healthcare costs. It is very important to stay focused on ensuring that patients have the right and the access to care. As pharmacists see this increase in influx of people coming in with insurance, they will continue to be able to focus and improve and focus on medication adherence. So as they continue to focus on medication adherence, there's about $1 billion across the U.S. of avoidable healthcare costs just in patients not being compliant with their medications. So pharmacists will be a great solution to that problem.
Medication synchronization is the process where the pharmacist synchronizes or fills all of your prescriptions, generally maintenance medications once a month, so that it cuts down on the trips to the pharmacy. We will call the patient ahead of time, let them come in just once a month to pick up their medications. As a local pharmacist, it's a roadblock to getting someone started and getting them adherent. Okay? Adherence is one of the major driving factors in lowering healthcare costs. A patient who is adherent or takes their medications the way they should every day, every month, has better therapeutic outcomes. Their disease states are generally better managed. A diabetic who has difficulty taking their medication on a daily basis will have higher blood sugars, worse outcomes from that disease. So if we're able to help them with either compliance packaging, which is where we put all their stuff in a monthly little calendar card, or if we're just filling them in bottles, they have all their medication at all times. They don't run out, and they're able to stay compliant and stay on the medication the way their doctor prescribed.
In order to bring down the cost of drugs for patients, what needs to happen is gag clauses need to be removed from contracts between pharmacists and the pharmacy benefit manager. A gag clause basically makes it impossible for a pharmacist to proactively discuss pricing and costs with a patient on their medication. With that removal, they can have a more open and honest conversation about what is in the best interest of that patient.
As a local pharmacist, we try to protect our patients from clawbacks because we have our patients' best interest at heart and don't want to see them overpaying for medications that they could obtain less expensive.
What is a clawback?
A clawback is something that's instituted by a pharmacy benefit manager or PBM, which is usually unseen by the patient. So, for example, the pharmacy bills for a prescription, which is typically a generic, and just for easy numbers' sake, let's say the pharmacy bills $100 to the pharmacy benefit manager. The pharmacy benefit manager may then pay the pharmacy $25, but charge the patient $100, and the pharmacy benefit manager keeps the $75 for themselves. So the patient ends up overpaying because the pharmacy's regular cost of that medication is somewhere around $25. So if the patient were to ask if the cash price is less expensive for the medication, the answer would be yes. But because our contracts prevent us from telling the patients what our actual price is when they have insurance, the patient is often unaware that they're overpaying for the prescription medication.
What needs to happen?
The gag clause needs to be lifted from our contracts and allow us to tell patients when they are being overcharged by their insurance company and give them the option to pay cash if in fact the cash price is less expensive than what their copay is.
Is this something that the legislature needs to address?
Absolutely. Absolutely. The clawback and the gag order needs to be addressed to help local community pharmacists continue to care for their patients.
Running a local pharmacy is a business. How does that impact your business when this happens?
It impacts my business because I truly put my patients' care, health, and well-being of that cost as a factor first. As a business owner, obviously we're in business to make money, but I don't feel good about overcharging patients when I know for a fact that they're being overcharged. It also puts me in the middle of a contracting issue where 3 of the largest pharmacy benefit administrators dictate 80% of the claims that are being processed. So in the event that we were found to be in violation of those contracts, we jeopardize being kicked out of those contracts, which would be a huge detriment to our business. So the pharmacist really can't disclose to the patient that they are being overcharged. It's up to the patient to ask, is this the best price that I could be receiving for this medication? That allows us to explain to the patient that they are being overcharged.
So I want to talk about comprehensive medication management. This is a bill that's working its way through the legislature. Comprehensive medication management would allow a pharmacist and either a physician or nurse practitioner to work more closely together to optimize medication therapies for chronic diseases. And by chronic diseases, I mean diabetes, high blood pressure, and high cholesterol are examples. There's other examples, but those are the ones that come to mind.
What is the situation now, and what would it mean if you were able to get that bill passed through the legislature? How would it affect the patient?
The patient, should we get this bill through the legislature, would be able to work more efficiently with the pharmacist to help optimize medication therapy for the treatment of chronic diseases. So it would allow more efficient management of the medication. It will allow the pharmacist to change dosages, order laboratory tests, and provide the counseling, of course, that patients have come to expect. But the idea is to optimize what we're doing with chronic disease to help minimize the secondary effects of those chronic diseases.
How would that benefit the health of patients throughout the state of New York?
Patients will have better control over their disease. As it stands, although we have great drug therapies for these diseases, they are difficult to manage. So pharmacists can help provide a more discrete level of management for the diseases to help get better outcomes from the diseases, help to lower the blood sugar, help to lower the high blood pressure, and help keep that cholesterol level down so that less likelihood of a heart attack or some secondary result of the high cholesterol.
We are all very well aware of the cost of drugs, and it is a challenge for some with health insurance where sometimes the copay may be higher than the cash price of the medication that they are being dispensed. And unfortunately, through contracts with pharmacy benefit managers, pharmacists cannot proactively explain that to a patient. A patient currently has to ask their pharmacist about that situation, and most do not realize that they should be doing that.
There's a high proportion of every $100 that goes into spends on drugs, $24 is administration. $15 goes to the pharmacy to dispense, optimize use, et cetera, et cetera. So part of this whole clinical integration conversation is how do we create a different way of getting paid for drugs? How do we create a different set of incentives and leverage so that we're not just dispensing pharmacies, we're healthcare service providers that happen to dispense and use that dispensing activity as a way of engaging the patient.
PBM, or a prescription benefit manager, is an entity that's hired usually by an insurance company to manage the prescription benefit. You know, when a patient walks into the pharmacy, they present their insurance card, and they don't know what happens from that point on, but 15, 20 minutes later, out comes a prescription and what they're going to pay. So the PBM actually interacts between the pharmacy, verifying eligibility, not only of the patient but the drug, with the insurance plan. And so they're the go-between, the entity that's there. And they serve a valuable purpose, in all honesty. I think the challenge has been, though, is that as the prescription drug market has grown dramatically, whether it's the cost of medications, the increased number of utilizers, and everyone's focused on the cost of prescription drugs, there's been a lot of things outside of the human eye that have been going on where the PBMs are negotiating supposedly better pricing. The question is for who? Some of the health plans are starting to question that relationship now. The pharmaceutical manufacturers are starting to question those arrangements, and government is starting to question those arrangements. And listen, there's nothing wrong with anybody making a buck. The bottom line is we don't even know who's making the buck at this stage of the game. And with all the pressures on healthcare, as we see health insurance premiums come out of every individual's paychecks, it really requires the highest level of scrutiny, which is why I've been pushing for years for greater transparency of PBMs and to hold them responsible as fiduciaries. The challenge is that some entities, those who execute agreements with these PBMs, don't really understand the terms and conditions that they're engaging with. So therefore, the PBM is actually exercising the rights under the contract, and the entities don't know any better. But as more and more examples are starting to come out, it's very clear that whether they're called incentives for payment or disincentives for payments, there's definitely an inequity that's going on, and that at the end of the day, people still want their right to choose a pharmacy, but they do not want predatory reimbursement impacting which pharmacy they can go to.
How is this affecting the cost that the patient pays and the pharmacist reimbursement?
At the end of the day, one can only guess that a lot of payment has been going on for prescriptions that is excessive. And at the end of the day, the health insurance plans have no other option than to look at what they're going to charge in rates for premiums or what they're going to charge in copayments. And a very common thing I see now more than ever before is differing copay structures, and they're not going down, they're going up. So it affects the consumer at the counter.
A pharmacy benefit manager is an entity that acts in the middle between the pharmacy and the drug manufacturer and the patient's insurance plan. What they're supposed to do is to make markets for the drugs so that the consumer enjoys better pricing. But in fact, what we've seen happening since they've become prominent in this line is increasing drug prices and increasing drug shortages. There's no transparency with pharmacy benefit managers. A consumer doesn't know who their pharmacy benefit manager is. A consumer has no choice over who their pharmacy benefit manager is. And there's been allegations that these companies have been taking money improperly from the manufacturers and from the retailers and not passing that along to the consumer.
What do you feel needs to happen?
I think there needs to be more oversight. Perhaps the role of the PBM is overstated, but I think the first thing we should have is some oversight.
Unfortunately, medication's not getting any less expensive. And, we deal with that as pharmacists, as providers, in the sense that we have to purchase and maintain an inventory and then dispense that to the patient and be paid for that. But it also affects our patient because they have to pay for it as well, whether it's through an increasing copay or a high deductible healthcare plan where they may not have drug coverage until they spend a significant amount of money out of pocket. So it's been a true potential barrier for care. So our patients are concerned about it, pharmacists are concerned about it, and we do everything we can to work with patients and providers to ensure that we keep their costs as low as possible.
There's a merger between CVS, which is a drug chain, and a PBM, Pharmacy Benefit Manager, and they have placed a bid to acquire one of the major health insurers in our state, Aetna. The concerns that I have relating to this is that there's tremendous consolidation that this merger would represent. I believe that they could have very, very negative consumer effects. There would be reduced choice. There would be the same people that are collecting the premium telling you what pharmaceuticals and what therapeutics you can have. And they might even be directing you to patients to their own healthcare providers. One of the things that I've observed about America is that consumer choice tends to drive innovation. And this clearly has a negative impact on consumer choice, and I fear on innovation in healthcare.
In 2015, legislation was passed in the state of New York to bring a higher level of transparency to the reimbursement of certain generic medications. This legislation is just not working. These generic medications are reimbursed at something called MAC, or maximum allowable cost, by PBMs. PBMs solely, at their discretion, set the prices for these certain generics. What is a PBM? A PBM is a pharmacy benefit manager. They were originally established as just a prescription claims processor, and their role has just continued to expand. They create plan designs for employers, they create formularies, they establish networks with pharmacies, they establish contracts with manufacturers for rebates, aggregate rebates for other PBMs, and they, in those pharmacy networks that they establish, sometimes they're limited networks, therefore limiting the access for patients to all pharmacies, and they can only go to a very few. In 2017, one of the larger PBMs drastically reduced the reimbursement to certain generic medications for pharmacies. Pharmacies were experiencing 20, 50, upwards of 90% below their cost of what they paid for the medication inside the consumer's bottle. Pharmacies were starting to question, am I even going to be able to remain viable? Am I going to be there for my patient? They had to make hard decisions and stop carrying certain medications because they couldn't afford to carry the inventory. This large PBM really caused issues for the consumers in being able to access or potentially access their pharmacy in the future. Pharmacist-patient relationships are just so critical to the whole overall healthcare system. Urging our people to assist us in making changes to this MAC appeals legislation that was passed in 2015 to make it more enforceable, bring a higher level of accountability to the PBMs and some form of regulation will give peace of mind to our consumers and allow them to understand that their pharmacy will be able to remain viable and be there for them. The access to their medications, their necessary medications, will be there, and they will be able to continue to foster the patient relationship with their community pharmacist.
In 1995, PSSNY decided that it was time that we tried to advocate for pharmacists in New York State to get them the immunization rights. Other states had already started to do it, and so we decided that PSSNY needed to be the leader to obtain this for pharmacists in New York. So we started lobbying. It took us 13 years. In June of 2008, the legislature came through with a bill that allowed pharmacists to administer both flu and pneumococcal vaccines. Now, our goal, right from the very beginning in 1995, was to allow pharmacists in New York to administer all vaccines that are given in an adult dose. It also was to allow for a statewide protocol or standing order. It was also to allow for no sunset for the bill, and it was also to allow for certified immunizing interns during their fourth-year rotations to immunize under the supervision of an immunizing supervising pharmacist. So those were our original goals. In June of 2008, we were delighted to get what we got, but our goals still remain all of those bullet points, okay? Over the years, and of course I have to say that in 2008, when we obtained this authority, there were 0 immunizing pharmacists in New York State. So again, now that we've got the authorization, PSSNY needed to do something about getting a pharmacist base that could immunize. So again, we took the bull by the horns. We set up a CDC immunization certification course administered by APHA, and 30 of us from throughout the state, under the guidelines of PSSNY, became not only certified immunizing pharmacists because we went through the course, but we also became administrators. We could administer and train other pharmacists in order to immunize. So we spread out throughout the state. So we went from 0 immunizing pharmacists in 2008 to 14,000 pharmacists today. And over that time, little by little, we have gained certain vaccines. We gained Zostavax. We gained Tdap. We gained meningococcal vaccine. So anyway, our goal is to still be able to administer all vaccines given an adult dose, to have a statewide protocol as opposed to what we currently have, which is a county-by-county protocol. And we need to have the sunset eliminated because the sunset will eliminate, or will expire in June of 2019. So if that's allowed to expire, pharmacists won't be able to administer flu vaccine for the flu year of 2019. So that needs to be eliminated. We also need to allow interns to immunize under a certified immunizing pharmacist once they have gone through the certification process. So these are all things that need to be done, and I'm thankful to say that we do have legislation out there. There's Assemblywoman Paulin and Senator Robach have legislation, and we need, as pharmacists, need to support it, and people in the public need to support it because of the fact that pharmacist is the easiest place we have the most access in order to get your immunization.
How would it help your fellow pharmacists and your customers if you were allowed to provide immunizations?
Oh, I think that would be tremendous. We've practiced it already. I am licensed to give immunizations as soon as the legislation passes, and actually when I become a pharmacist. But at the moment I can't even train, I can't practice. I can watch Paul, the other pharmacists, do it, but I can't. And I think that'd be a real help to be able to practice it and get familiar with it.
Would your customers benefit from that?
Yes, I think they would. It would certainly be a help to us too, and that would again build that rapport.
My name is Kevin Lavery. I'm a student at the University at Buffalo School of Pharmacy and Pharmaceutical Sciences. I am currently an intern in a pharmacy, an outpatient pharmacy. I've learned a lot about immunizations since the beginning of my schooling, their importance for preventable diseases, and really just our goal is really just to expand how many immunizations we can do, the number of people that we can immunize, the geographical areas of which we can immunize, really help underserved areas by immunization expansion, as well as just expanding vaccinations to students. Getting students able to immunize is extremely important. New York State is one of only 4 states remaining in the entire country that does not allow pharmacy students to immunize, even though we have the same training as a pharmacist who can immunize. So it's very important that we extend immunization roles to students as well.
I work in an outpatient community pharmacy, and actually my pharmacists conduct flu shot clinics where they go to different sites, including like colleges, high schools, to immunize the employees as well as any adults that are there. And I know that sometimes they were overworked, too many people coming to the clinics with only one pharmacist. Being able to immunize, it would help if the students were also able to immunize. It would take some of the load off the pharmacists. We'd be working directly with them, so we wouldn't be by ourselves at all. And I think it would allow a greater number of patients to come to these clinics so that we can help immunize more people in the community and help the preventable diseases to stop spreading.
It's very important for students to be able to immunize for a few reasons. First being that there's often a 2-year gap between when a student acquires his training and when he can actually, when they can actually employ the skills in the community setting. So, for example, a student goes through a formal education training in which they give a fellow student an immunization, and we are trained. However, there's often a 2-year gap before we are actually allowed to legally perform these duties in the community pharmacy. So it's really important that by allowing students to immunize, we can narrow this gap and allow them to get more practice, learn the tips and tricks from the pharmacist while they have that direct supervision before being thrown directly into the community pharmacy on their own to learn those things as well, to gain experience. And it's extremely important for patient access as well, especially when it comes to workflow in the pharmacy, as well as just getting more people, more exposure. Having more interns would open exposure to vaccines in general, and just like really expanding the access would help patients and improve outcomes and reduce preventable diseases.
We would like to see several bills passed, including increasing and expanding the ability to immunize. Right now they are only limited to the number of vaccines that they can administer. We would like to see that expanded. We'd also like to see pharmacy interns who are educated in immunization being able to provide that during their school years so that they are well prepared when they become licensed pharmacists to continue to do so.
And how would that improve the health of the people in the state of New York?
Well, expanding access to immunizations is very important. That is one of the goals of the Department of Health in this state, and we would like to support that goal. We believe that those that are immunized are going to be healthier overall, and if more and more people are immunized, those that cannot be immunized are better protected as well. Well, the governor's budget is very important. It sets the policy and the tone for healthcare across the state. It's a challenging year with many fiscal issues, and it's important that we improve the working environment of the pharmacist so they can provide more care to their patients. Some of the issues that are facing pharmacists not only include, fiscal implications, but their ability to treat patients at the top of their license, and that means using their license to the best of their ability, to the highest level that they've been educated, to improve their patients' health care.
So far, no further cuts to pharmacy reimbursement. I don't know what you're going to do with the 8 cents per prescription that you get. Don't spend it too quickly, all right, because we don't know what NADAC is going to bear out to be. But, and to be honest with you, I still have some quibbles about, I know this is minor, this is peanuts, but taking the OTC copay from 50 cents to $1 is basically saying, okay, well, we're just going to take another 50 cents from you because you know damn well you're not going to get the copay in the first instance. And then I think they're basically going to take every OTC off the list. I mean, when they start taking cough suppressants off the list and taking off antacids, what's left? So it's going to be a very interesting dynamic in that aspect. I'm curious to see what they're doing. And so that being said, I guess I'm glad in one aspect that they didn't cut us. On the other hand, as some people may say, what else can you do? You've pretty much done as much as you can do at this stage of the game. That being said, heads up, today's only January 26th. April 1st is a long ways away, and a lot of things can happen between now and then. So we have to be ever vigilant. We need to keep our guard up. I can tell you, I work with all entities of pharmacy, and we're constantly in communication on a regular basis throughout this process.
The drug disposal bill of the governor's last year that was vetoed. Do you have any comment on it? I know it's coming back in the Senate, and I believe it will be in the Assembly.
Yeah.
With manufacturers and paying for the bill or the.
Yeah, I was not supportive of that bill from last year because I also worry about, granted, it was, some people say, well, what do you care? You own an independent pharmacy, it's chains. No, it's a philosophical issue. You're laying this cost at the feet of pharmacy in general. Now, some of us, we willingly will pay for medications we dispose. We do that as a public service. That's fine. The challenge, and this is the whole challenge with the opioid tax to a degree. The reality is this crisis that we're dealing with, it didn't happen overnight. I go back to the 1980s when I was actually the legislative liaison for PSSNY, speaking at the hearings about the fact that we were witnessing patients living a life writhing in pain because doctors were afraid to write for pain medication. That's where the pendulum was back in the 80s. So everybody, from the federal government on down, went through a different perspective of trying to make sure that we provide proper pain management. Along the way, everybody participated. I'm not saying everybody benefited, everybody participated. The manufacturers did their thing. They went out there and OxyContin's the next best thing since baby aspirin. Everybody should be on OxyContin. We know that's not the case. The wholesalers just filled orders as they came in. Regardless, they did, they're saying, listen, pharmacies are filling out the form. We're going to send them the order. Why would we question them, right? DEA didn't do anything. CDC didn't change any guidelines on how we should address pain, whether it's chronic care or acute care. So they did their thing. We, pharmacists, patient comes in with a prescription, looks legitimate, we're going to fill a prescription. Whether it was for 8 hydrocodone from the ER or 79 pills from the ER from hydrocodone, because we had these crazy quantities going on. And then we have the patient who basically has been brought up a whole generation that they should never live a moment of life in pain, that they need to take a pill to get rid of their problem. So society in general owns this issue, And society in general is going to have to work its way out of it. And that means everyone's got to play their part. I just don't want it to be an unfair burden.
A local pharmacist is your best advocate when it comes to part of your healthcare team. We are kind of the last line of defense in prescribing medication. We check for drug interactions, proper dosing. We check to make sure that things just make sense on the medication that's being prescribed. As a local independent pharmacy, I have the ability to be very flexible with my policies and procedures. I don't have to answer to corporate guidelines or corporate metrics about how many flu shots I give per day or how many turns my over-the-counter area does per month, per week, per year. We are able to have the flexibility and be nimble in our decision making to make the best decision for our patients on a case-by-case patient. So we really are able to treat each patient as an individual, not as a corporate policy. And whether we bend our own policy because there's an extenuating circumstance, we really go above and beyond for our patients. I'm a second-generation pharmacist. My dad opened our business in 1963. There are several others here that I am not an unusual circumstance. Pharmacy is really a family business. We try to treat every patient that comes into our pharmacy as extended family, and we offer them care as if they are extended family.
Mail order has become a scourge in our state. Patients' choice has been limited by their insurance companies, and as pharmacists, we feel that for better patient care and patient safety, that patients should be allowed to have a choice of where they get their medications. It's really become an issue for us as business people and also for the health of our patients. It's better face-to-face meetings with pharmacists than having to do it over the telephone. We have even passed legislation in New York State that was supposed to eliminate mandatory mail order, and now we're trying to get that bill adjusted. Senator Golden and a member of the Assembly, Joyner, are working with our society to try to get that law working a little bit more in favor of patients having a choice of which pharmacy they want to use.
What is the advantage of patient choice and being able to get the prescriptions filled face-to-face as opposed to mail order?
Well, a face-to-face conversation with one's pharmacist is certainly a better relationship. Patients have developed relationships for long periods of time with their pharmacists, somebody that they know, they trust. They're more apt to discuss personal matters with someone that they do know on that kind of basis. And we certainly see the patients far more frequently than any other healthcare professional, being as they do stop in the pharmacy on a very, very regular basis. Also, on mail-away prescriptions, you have issues of how is the medication shipped, how is it stored, is it going to arrive on time, what if if I'm on a mail order and I get a very large supply of medication and then all of a sudden the dosage is changed, that medication is wasted, and there are huge amounts of waste in mail-order pharmacy. Plus, it hasn't even been shown to be less expensive for the consumer or for the insurance company.
Let me give you an overview of a chain supervising pharmacist. Supervising pharmacist in New York State, whether it's in the chain setting or the independent setting, is really the same. We are responsible for adhering to the rules and regulations of the State Board of Pharmacy in New York. The difference, truthfully, is in today's setting with the shrinking margins because of things such as non-PBM transparency or MAC appeal, our margins have shrunk to the point where it's very, very difficult to make a profit. In the independent setting, that directly affects their bottom line, whereas in the employee setting, as an employee of a big chain, we don't feel that. However, we do feel it because our employer has to reduce their expenses, and one of the very few places that they can cut is payroll. So let's just say that I need 100 hours a week of tech help in order to function properly. I'm probably only going to get 80. And that directly affects customer service and customer care.
You mentioned the fact that it's difficult profit margin-wise for pharmacies throughout the state of New York, but with the high cost of drugs, that patients may wonder, why is that?
Well, the high cost of drugs is directly related to the fact that manufacturers have no price control, so they can charge whatever they want. If we were able to make a reasonable profit off of whatever the drug costs, then it wouldn't be an issue. However, because there's no transparency with the PBMs, we really don't know what the insurer is being charged as opposed to what we're being paid. And there's where the difference is.
You mentioned the PBM. That is typically known as a middleman. Explain how that system works.
Yeah. The Pharmacy Benefit Manager, which is the acronym of PBM, is a middleman. What they do is they contract with insurers in order to manage that insurer's patients' health care. It impacts the cost of drugs because of the fact that the PBM is charging the insurer one price, they are taking a fee for their service, and they're paying the pharmacy a different price. And what that spread is, we don't know. Nobody knows because there's no transparency.
And what kind of an impact is that having for both the patient and for the pharmacist?
Well, for the patient, what ends up happening is that their premiums go up and up and up and up, so their health care costs more every year. For the pharmacy, our margins shrink and shrink and shrink because the difference of what we are paying for the drugs and what we're being reimbursed by the PBM becomes narrower and narrower every year.
What needs to be done in your estimation?
My estimation is there is current legislation out there that would mandate PBM transparency. In other words, we can see where the difference is, what the PBM is charging the insurer, what they're paying the pharmacy provider, and what the difference is.
Message today is to talk about fair audit reform. This is a bill that's sponsored in the Assembly by Charles Levine and in the Senate by Senator Marty Golden. So I want to talk to you about fair audit reform. First, I'd like to start by telling you that well over 90% of the prescriptions that are filled in community pharmacies and throughout all pharmacies are covered by an insurance plan, which include a pharmacy benefit. And for this reason, it's appropriate for agents of insurers, health plans, or other payers to conduct audits for claims submitted to them for payment. The problem arises when some of the audit practices are unreasonable, excessive, and sometimes invasive. And I'd like to give you a few examples of that. Total recoupment can be excessively punitive. And what I mean by that is sometimes auditors will claim or take back the total amount of claim or a prescription based on the fact of a clerical error or a typographical error when there's no harm to the patient or the payer. Secondly, many times the pool of prescriptions that they choose are your most expensive claims. This legislation allows for a random sample to be conducted and no more than 100 prescriptions in a 12-month period. Other times you get an audit and you don't get the results for 6 months afterwards. That is too long because if they require supporting documentation after that, patients could have moved, physicians are no longer reachable, so this legislation calls for a 45-day turnaround. And then there are times where you just get insufficient notice or workable timetables to comply with an audit. This bill standardizes procedures and protocols and timeframes in an audit without affecting the ability to detect any fraudulent activity. Of course, we support uncovering fraud in wherever it may occur. But we truly believe that a pharmacist's time is best spent counseling their patients about drug interactions, about allergies, and consulting with their prescribers so that they may achieve the best possible outcomes. Fair audit reform has been passed already in over 30 states, and we look forward to getting it passed here in New York in 2018.
My name is Charles Catalano, and I am a consulting pharmacist. Many of you probably don't even know what a consulting pharmacist is, but basically I'm the pharmacist who basically is contracted with a long-term care facility. Now, a long-term care facility, you might know, is one of two things. It's either a group home, which individuals live that have some kind of developmental disability, or a skilled nursing facility, where you may have a patient or a friend or a family member who resides in one of these types of locations. A consultant pharmacist is an individual who goes into these homes and reviews exactly what medications these individuals are taking. He's independently contracted. He doesn't work for the nursing home. He works for basically himself, and he's contracted through the agency. What he does is he compiles all the medications which the individual is taking. He gives a report to the director of nursing and makes comments to the medical team on whether or not the most beneficial drugs to be taken by these individuals. If the individual has to be hospitalized for any reason and there's a change in the drug regimen, the pharmacist is alerted of that and is asked to comment on those new drugs. The pharmacist is the ultimate decision maker, works with the provider to determine what the best medication needs are for your family member who may reside in one of these homes. Medication regimens are very complicated. There are a lot of drug interactions. Some medications should not be taken together. Some medications should be taken at a particular time of the day. A lot of times all the doctor writes on the prescriptions basically take once a day. But what's the best time to take it? Is it with a meal, for a meal? Is it with lunchtime? Is it before dinner? Or is it bedtime? A pharmacist should be able to ascertain what medications, when's the best time to take that medication, depending upon what other medications they may be taking.
A compounding pharmacy is a specialty pharmacy that customizes patient-specific medications exactly for your needs prescribed by your prescriber. We do anything from making different dosage forms that are not commercially available, making things that are flavor-free or extra flavors in them. We could do things from suppositories to lollipops to capsules and creams, but everything's very specific for the patient, customized just for you.
What are the issues facing a compounding pharmacy?
Well, compounding pharmacy faces different issues of what they can make and when they can make it and how they can make it. So there's a lot of guidelines that we follow to make sure that your product for you is not only correct for your specific needs, but also meets certain standards of potency and sterility and how long it's going to last and how well it's going to work for you. Issues that you can't get a certain product, let's say in a commercial pharmacy. So say you go into a local pharmacy and they have shelves full of bottles with pills and tablets. My pharmacy has shelves full of powders. So actually we make things from scratch just for you in different dosage forms that are very specific for your needs.
Is there an issue before the legislature that is important for the public to know about when it comes to compounding pharmacies?
Well, the thing with compounding pharmacies is that a lot of it is not covered by your insurance company. They have different rules and regulations. They have their own rules and regulations for what a compounding pharmacy can make for you. So that's one of our biggest obstacles that need to be addressed. The fact that certain insurance companies will not pay for your compounds, even though it's specifically just for you, prescribed by your doctor.
What will it take to improve that situation?
Well, the insurance companies need to hear from the legislators and need to hear from their patients that this is something that they need, and it helps them really with their quality of life and their increased health outcomes.
Sustainability is value. So where does the value come from? There's two places you can generate value from. You can generate value by making something cheaper, or you can create value by creating something that you get more from what you spend. When it comes to the Owners Academy, what they need to be is in the services market on the value proposition that increases the output. What kind of output are we talking about? Better hemoglobin A1Cs, keeping patients out of the hospital, keeping patients out of the prison system, less recidivism, less behavioral health issues. And so it's taking the medications and optimizing them so that you can express that value, so that it's not about, hey, I need to cut your rates in order to prove value because I'm just going to spend less on the drugs. It's that you're going to get much, much more out of the drugs for what you're already spending on the drugs. It's a different equation.
The future of pharmacy is really a service-based profession. We are now looking at providing service and care beyond the medication in your bottle. We feel our role as a pharmacist is to be collaborating and working with other healthcare providers in taking that care for our complex patients, chronically ill patients, who need more services than just having a prescription filled cheap, accurate, and fast.
How is that going to benefit the patients?
It benefits the patient by getting a better understanding of their medication, increasing their adherence. When you know your medication and why you're taking it and the reasons behind it, you get a much stronger buy-in in staying true to that medication and that therapy.
What is the value of a patient going to a local pharmacy as opposed to a mail-order pharmacy?
Well, what's great about owning your own pharmacy or being a pharmacist in an independently owned pharmacy is you have the flexibility and the drive to change as the needs of our patients change. As new needs and services are required, it's usually a decision just by the owner and their staff to how they can fill that need for that patient and improve their care.
From the academic side, the future of pharmacy is how do we align our skill set better with patients? So one way to think about that is quality care and value-based models. So how we're teaching our students and how the opportunities are going to come about in the future is we're going to align ourselves not by a volume-based activity, so for example, how many prescriptions we fill, but how we take care of the patient. So all of the other outcomes that are important not only to the patient, but also to the healthcare system as a whole. And this is how we need to begin to align our services.
Tell us how pharmacy students are prepared by the universities when they come out.
Pharmacy students are prepared very robust in many different ways. So they obtain a specific skill set that allows them expanded clinical tools, but also communication tools as well. So we might have the best plan and idea for the patient, but if we don't approach it in the correct manner and way, we might fall short in our goals. But pharmacy students today not only have the hard skills, the clinical skills, but also developing the very important soft skills and how the interpersonal relationships can play out in a patient encounter and interaction.
What is required for a student to become a pharmacy student?
Well, to become a pharmacy student, they have to go through a vetting process, admissions, and they have many criteria that they need to meet. So many programs are designed with prerequisites. Others accept right out of high school, and they have an opportunity to grow directly into the program. But beyond that, once they get into the Doctor of Pharmacy curriculum, it's a very aggressive and robust curriculum that teaches them many different skill sets and really teaches them in a way that they're going to be practicing in the future of pharmacy.
I've been working here 5 years now. As an intern, it's been 2. I am in my 5th year of pharmacy school, and I love working here.
What about getting to know the customers?
I think it's crucial. I talk about it all the time in a lot of our classes. Getting to know them, build a rapport with them, they'll feel more open to talk to you about things, and you can delve deeper into problems that maybe they wouldn't otherwise tell you if you didn't know them.
Oh, it's a tremendous value. One, for the customers, you pick up things that you wouldn't if you didn't know the person. And for me, it's a very satisfying career to know all of my customers.
So we're fortunate enough to see our patients. We know our patients. We recognize them when they walk in the door. Healthcare's local. It's very local. We provide services that you can't through the mail, and I don't mean any disrespect to our postal carriers. Pharmacies, we know our patients. We have to be advocates for them and advocates for ourselves.
The local pharmacist has been, year after year, has been voted the second most trusted professional. Pharmacists are here to help the community to make the community healthier, and the only way we can do that is if we dispense the medications to our patients.
What I would like the public to know about local independent pharmacies is that they are invested in the community. They provide care for neighbors, basically, and so they have a higher level of interest and expectation and have a greater level of care for the individuals who are their patients.
The local pharmacist is your best line of defense for your prescription medications, whether it be checking for drug interactions, correct dosages, making sure that everything is compatible with your complete drug regimen, but we're also a steward of making sure that you're receiving the best price possible. It's something that the patient needs to be empowered to ask, and don't hesitate to ask us about pricing, that is this the best price I could be paying for this particular medication.
People should keep in mind that their local pharmacist is on the front lines. They're the most accessible person in their healthcare chain, and they're here to help them. And the access is what's most important. Generally, your local independent is the most accessible. So this is what we're hoping to get across and get more people talking and more people in speaking with their pharmacist.
The importance of a local pharmacy is having that relationship with people that have been in the community, that are your neighbors and families. They usually have a much better relationship with their doctors in that community and give you a better level of care.
Your local pharmacy is important because they're in your community. They're part of your family's friends and neighbors. They're local to you, and they know who you are. They know who your family is, and they know what your needs are. You can come into your local pharmacy and know everything about your kids and your children and your parents, so it really helps tie in for your total health care needs and outcomes when a pharmacist knows everything about your family and what they're taking and what they need from you to them.
The unique relationship between a patient and a pharmacist is that a patient sees the pharmacist more than any other healthcare professional across the spectrum. It gives them ample opportunity and multiple opportunities to discuss their concerns, their medications, and what might be of interest to them, what might be concerning them, and getting better advice more frequently is always a good thing.
We are always working, PSSNY is always working to expand our scope of practice, to be able to serve our patients better and to have better health outcomes in the system, and especially in New York State at a lower cost.
I would like people to keep in mind that pharmacists are there to support them, to care for them, and that with improved working environment, they could do even more.
If people have questions like more information about the organization, what should they do?
They should visit our website at www.PSSNY.org.
The 2018 PSSNY Annual Convention will be happening in Buffalo this year. It is the first time in many, many years that it's been there. It will be on June 22nd through the 24th, and we hope to see you all there.